I'm talking on infections of the hand. This is quite an extensive topic, and hence we have split it in half. So I'm talking on the first half, and then Parag will take over. So I begin the talk. My screen is not moving. Yes. Yeah. So I make a mention of this gentleman, Dr. Alan Cannabell. He was a general surgeon from Chicago who treated hand infections in the pre-antibiotic area. And his extensive dissections and innovative injection studies have helped us base our knowledge and treatment protocols of hand infections to a great extent. Hand infections are quite common. They can result in severe disabilities such as stiffness, contractures, or also amputation at time. The antibiotics have helped us to a great extent in dramatically reducing the morbidity and associated with these infections. They, however, do not replace the need for surgical interventions. There are several factors which influence the outcome of an hand infection. These are the location of an infection or the infecting organism, the timing of treatment, adequacy of surgical drainage, efficacy of antibiotics, health status, and immunocompetence of the patient. The etiology of the hand infections can be different. It can be due to an open injury caused by trauma, animal bites, human bites, drug abuse. It can be due to hematogenous infections or iatrogenic infections caused by pin tracks or surgical sites. So the typical pathophysiology of any infection is after the bacterial inoculation, there is acute inflammation, which results in an increase in the compartmental pressure, reduced vascularity and circulation of that, leading to tissue necrosis and abscess formation eventually. Alternatively, the bacteria also secrete some toxins which can lead to tissue necrosis and abscess formation. This is the bacteriology associated with hand infections, which we must be aware of because sometimes they have a really different kind of presentation, and that leads to inadequate or inappropriate treatment. The Staph aureus or the Streptococcus are the most common organisms. However, sometimes there can be a mixed picture or a mixed or a multi-organisms causing infection. These are the mycobacteria, which are very common in this part of the world, and these infections are noted on and off in some patients who are not responding to the standard line of treatment. As it takes two to quarrel, so it takes two to make a disease. So along with the microbe, it is also the host which is important to determine how the infection takes its course. There are several host factors which determine how the infection will progress. The age of the patient, diabetes mellitus, malnutrition, alcoholism, autoimmune diseases, chronic corticosteroid use, renal failure, hepatitis, and HIV. All these have a severe impact on the progress and outcome of infections. Certain occupations are more prone to specific kind of infections, so the history of the patient can give us an hint of what the infection could be, such as the herpetic whitlow, which occurs in medical and dental professionals. Gardeners more often pick up sporotrichosis. Chronic paronychia is common in people exposed to water and detergents. Marine workers and animal farmers are exposed to typical organisms. The patient evaluation is important, like in any other situation. The local examination will indicate pain, tenderness, increased temperature, erythema, swelling, painful movements, fluctuation, and pus discharge. Systemic signs such as fever, myalgia, chills, lymphangitis, and lymphadenopathy should be noted. Investigations depends upon what the condition is. In relatively early onset investigations are not really essential, but in chronic infections, yes, they do matter. The WBC count can be raised. The ESR or CRP are non-specific indicators, but they can give an idea of what is happening. Diagnosis of diabetes and its control is extremely essential. Wound swab may indicate what is the organism causing the infection. Tissue biopsy is also an indicator, and radiographs can give us an idea of presence of a foreign body or gas within soft tissues, fracture, arthritis, and osteomyelitis. The treatment principles in general, most of the cases require surgical drainage. A large incision is usually used. The incision should be extendable. It should minimize the exposure of blood vessels, nerves, and tendons, so as to avoid future healing problems. And we should avoid longitudinal incisions across the flexion creases. The wounds are most often left open The large wounds may be subjected to negative pressure dressings. Multiple debridements are usually essential to get rid of the infections completely. Loose dressings are often used, and there is no rush to close the wounds primarily. And many times the wounds are left for healing by secondary intention. The postoperative care involves frequent change of dressings, immobilization by splint, early mobilization to prevent stiffness. Multiple debridements are often essential in complicated infections. Amputation is sometimes a better option for a stiff, painful, or a non-functional digit. Empirical antibiotic therapy is started in most of the cases, and then it is shifted over to a specific therapy depending upon the culture. Uh, So the common hand infections are usually acute paronychia, chronic paronychia, pulps abscess or the phelon, pyogenic flexor tenosynovitis, deep palmar space infections, dorsal infections, infections of the wrist joint, and septic arthritis and osteomyelitis. These are some other causes which are not very uncommon: animal bites, human bites, prosthetic and implant infections, shooter's abscess, which are typically seen in parental drug abuse, septic thrombophlebitis, herpetic whitlow. Diabetic hand infections are gradually increasing, just as the diabetic foot is common. Necrotizing fasciitis and gas gangrene are special situations. These are some mimickers of infection which we must know so as to not misdiagnose these cases: gout, pseudogout, calcific tendinitis, pyogenic granuloma, pyoderma gangrenosum, retained foreign bodies, and metastatic and primary tumors. Acute paronychia. So this is the most common infection of the fingertip. It involves the soft tissue fold around the nail. It is generally treated by a primary care physician or a general surgeon or a general orthopedic surgeon, and hence it is very important to know the anatomy of the finger and the extent to which the infection can spread to treat it adequately and appropriately. Many a times patients are inadequately treated, and hence they'll end up with refractory or infections and complications. So this is the anatomy of the nail complex, the paronychial folds and the eponychium, and the pulp tissue of the finger. So knowing this anatomy helps us in knowing the typical tracks which these infections usually take. The infections typically occur by bacterial inoculation of the paronychial tissue uh, in a hangnail or a manicure instrument, causing damage or nail biting. The clinical symptoms are, as discussed already. The preoperative evaluations also is not required in many or most of the cases, but sometimes in resistant cases, yes, we do need them. These are the spectrum of cases with an early onset paronychia. This is a paronychia with an abscess tracking under the nail. This is a abscess along the fold which is started to drain itself. The treatment options in the early stage, antibiotics and rest and elevations do help. Superficial abscesses, the elevation of the cuticle helps in drainage. The incision and drainage is sometimes essential for adequate and complete drainage of the abscess. Antibiotics are given for a period of 5 to 7 days. The deeper abscesses definitely need drainage in all cases. The incision is usually directed away from the nail bed. The nail plate can be partly or completely removed so as to drain the abscess completely. We must always check for volar extensions of these abscesses because many a times they track along the pulse space or along the distal phalanx, and these can be missed. The bony involvement also needs to be assessed clinically as well as on X-rays. This is another method of drainage of the abscess in situations where it is tracking under the nail plate, where the eponychial fold is cut on both the sides and reflected, and the nail plate is then cut to expose the nail bed. Pitfalls: it may be misdiagnosed as an herpetic whitlow, in which case the treatment option is totally opposite. It is treated conservatively. In fact, surgical treatment of an herpetic whitlow may lead to systemic viral infection. Hence, it is important to know the difference in the two situations. Failure to recognize underlying osteomyelitis and atypical infections. Postoperative management is, as discussed, 5 to 7 days of antibiotics, frequent change of dressings. It may still land up with nail deformities if inadequately treated. A persistent or a recurrent infection can cause um, uh, problems again, and the scars may lead to hypersensitivity. Chronic paronychia is a different condition altogether. It is a chronically indurated and rounded eponychium, which results from repeated episodes of inflammation and drainage. There's thickening and grooving of the nail plate. It typically occurs in middle-aged women, the females being more common, frequent water immersion and exposure to detergent and alkaline solutions. Housewives, bartenders, dishwashers are more prone. Diabetics typically are more prone to these infections. This is
Dr. Nilesh, we will need to keep to time, please.
yes. So the infection begins along the nail folds, and then the repeated cycles of infections leads to fibrosis and thickening, leading to chronic paranoia. The treatment could be topical corticosteroids, topical antibiotics, or antifungals, and reduce exposure to these environments. Eponychial marsupialization is usually required to be done in such cases where a crescentic shape of eponychium is excised and the wound is left open to heal on its own. The nail removal simultaneously can be done if it is deformed. That also is said to improve the healing rates. Phelon is a pulse space abscess. The pulse space has a typical anatomy, which is described as a closed sac connective tissue network with multiple vertical trabeculations, and which are packed with fat globules. This is another picture showing the same. So it is an subcutaneous abscess of the distal pulp involving the septal compartments. It causes a compartment syndrome, with Staph aureus being the most common organism. The injuries could be penetrating injuries of finger stick phelons, which occurs in diabetics. The clinical symptoms is throbbing pain because of the high sensory nerve endings at the fingertip, tense swelling, but typically which does not cross the DIP flexion crease. It can lead spread to the bone or to the skin, or can lead to other complications. And the aim is to preserve the finger pulp sensations, the tactile sensibility, and the stable pad for pinch. These are the different incisions for drainage. The lateral incision is the preferred one. It is slightly dorsal to the neurovascular pedicle to prevent injuries to the neurovascular pedicles. All the septal compartments are released to drain the pus. The distal phalanx is assessed for any changes. The complications again are typically pulp atrophy, pulp instability, and amputation sometimes is needed for severe bone infection leading to refractory or recurrent infections. I'll just run into two cases.
Dr. Nilesh, can we come back to this if time permits, so that because we will have to move on. Dr. G. Balkrishnan, Dr. Ravi Mahajan are online waiting for us. So we will come back to clinical examples if time permits. Is that okay with you?
Yeah, absolutely.
Yeah, perfect. Thank you, Dr. Nilesh.